The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series. My name is Shanna McKernan, and today I'm interviewing Dr. Nahla Gafer from the Radiation S Isotope Center in Sudan, an author on palliative care in the global setting, American Society of Clinical Oncology Resource-Stratified Practice Guideline. Thank you for being here today, Dr. Gafer.
Good morning. Thank you so much, Mrs. Shannon, for this opportunity.
First, can you give us a general overview of what this guideline covers and what it means to be a resource-stratified practice guideline?
Yes. These guidelines outline and they cover the recommended set of palliative care integration concerning personnel needed, training needed for this staff, structure, and availability of medicines at different resource levels. And by a resource-stratified guideline, we mean that it's suitable for different levels of development or yes, for example, if you are speaking about a community level, we are speaking at primary care centers, or if we are speaking about a different setting like a regional hospital, and also the highest level might be the oncology center. And at every level, there should be a better structure and better training and availability of palliative care. But at all of these levels, we should have palliative care.
What are the key recommendations of this guideline?
Yes, the key recommendations, as I mentioned, is that we should have a coordinated system where the patient's palliative care needs are identified and met at every level and from the moment of diagnosis. So we are speaking about, at the basic level, we should have at least a volunteer or community worker, or better even a nurse trained in palliative care. And these people have got the job to facilitate the identification of patients who need palliative care at the community level. Another level is the limited level, and here we should have at least one doctor and a nurse trained in basic palliative care. And they work with the people working in the community, and they address minor issues, prescribing basic medicines, referring patients, and they also have the ability to support the patient and the family emotionally. At another enhanced level, and we are speaking here about a setting like a regional hospital, there should be a team, at least of 3 personnel: doctor, nurse, pharmacist. Of course, if there's a psychologist or religious chaplain, it's okay, but at least these 3 personnel should be trained about palliative care, so a minimum of 6 weeks training, and they can provide palliative care, and they can offer as outpatient service in this regional hospital. The best setting or the maximum setting is when we are speaking about a bigger hospital or an oncology center. And we are speaking that no oncology center or any facility for palliative care patients like hospices should exist without a well-developed palliative care team. And having personnel and all personnel working in that center should receive basic training in palliative care. The main treating doctors, for example, the oncologists, should have secondary training in palliative care. So it's a higher level of training in palliative care. And we need for palliative care physicians to supervise and develop the service. At such a setting, we should have psychologists, we should have chaplains, all integrated in the service. Another recommendation is that palliative care should be given and provided at all levels, or ideally at the moment of diagnosis of a patient, but especially for patients who are coming with overwhelming symptoms, whether physical, psychological, or spiritual, or patients who have metastasis or patients who cannot receive active treatment for curative intent, for example, for comorbidities or age, or patients with a disease with a known short life expectancy. All these patients should receive palliative care from the moment of diagnosis.
Why is this guideline so important, and how will it change practice?
Yes, it is very important because palliative care is important to be given to all patients at every setting. It is not expensive. It doesn't require special equipment. It can be given. It's not only should be given, but it can also be given. It's not difficult to change. And this guideline is very important because sometimes people don't hear other colleagues or junior doctors. They hear high recommendations like from the ASCO guidelines.
And finally, how will these guideline recommendations affect patients?
Yes, we hope that directors of hospitals, people or personnel at ministerial levels, our fellow colleagues, they embrace these recommendations more and more. As I mentioned, sometimes it needs to come from higher up, and for that we thank the American Society of Clinical Oncology for taking this task. Once we are caring for our patients holistically, which includes social, spiritual, psychological dimensions, in addition to physical, it leads to a better quality of life, affecting not only the patient and the family in all dimensions, but even leading to a better survival. And here I mean both in time and quality.
Great. Thank you for your time today, Dr. Gafer.
Thanks a lot.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer the show to a colleague.